Welcome back, everybody. My name is Dr. Cow, and today I am joined by my good friend, Dr. Brad Langston. Welcome, Brad.
Hi.
And Brad will be talking to us about EMIM as a residency option, and he does critical care right now. So he'll do he'll talk us through regarding what's it like to be a critical care physician as well. All right. So Brad, tell us a little bit about your background and what do you do right now as your job?
So I grew up in North Carolina and I went to ECU for medical school, East Carolina University. And I wanted to stick around North Carolina. So I decided to do a fellowship or residency at East Carolina as well. And one of the nice things that they offer is an EMIM combined program. And when I initially started medical school, I was thinking I was just going to do emergency medicine because I have a paramedic background. I used to
Mhm.
work EMS. And so I figured, I was just going to do emergency medicine and that was going to be my career choice and I was going to be happy with that. But when I was in medical school, I was rotating through internal medicine and rotating through the ICU. And I was like, you know what, I kind of like that stuff too. And so
Mhm.
I decided that instead of doing just emergency medicine, I wanted to broaden out my options. And
Mhm.
so fortunately, ECU, East Carolina, had an EMIM program. And so I fortunately got accepted and the rest is history.
Yeah, yeah. Brad and I trained together at East Carolina and Vidant. Uh, I
That's
was
right.
I was EM myself, and in my thought process, like there is no way I'm going to do 2 extra years of
So I was already a resident. I was a first year resident by the time you got there.
uh-huh.
And by the time you left, I was like at your graduation saying goodbye, and I was still a resident when you left. So that did kind of suck. So
Yeah.
yeah.
Do you think the extra 2 years of training is well worth it if you do want to go into the specialties or whatever you feel like you want to do with your career?
Yeah, for me personally, it was a
Mhm.
great fit because I truly enjoyed both aspects of both emergency medicine and internal medicine. So for
Mhm.
me, it was totally worth it. And especially now, since I'm doing critical care,
Yeah.
I'm critical care boarded, and I'm actually adding on a neurocritical care fellowship because you just never can get too many fellowships and boards. Um, the emergency medicine and the internal medicine just blend in perfectly if you're going to do a critical care fellowship because you get the procedural aspects of emergency medicine and then you get the intellectual nerdy aspects of internal medicine, and so critical care sort of fits all of that together. So
Okay. Yeah. You're a constant fellowship degree gainer.
yeah, yeah, yeah.
So let's talk a little bit more about EMIM before we
Sure.
move to critical care. Once you graduate from EMIM, what do most people practice? Um, Internal medicine or emergency medicine or both, or do they go in fellowship like you did?
So when I graduated, I actually started doing locums. And when I was working as a locums, I was doing emergency medicine work and internal medicine as a hospitalist. And I was also doing some critical care work as well. So I had the privilege of being able to take jobs where I was doing all three things. And so if the question is, what are your options when you finish? Do people really do emergency medicine and internal medicine? The answer is yes, you can. Most people with your hospitalist job, you
Hmm.
typically work about 1 week a month, and then you can set it up so that you do the rest of your time doing critical care. At the hospital where I trained at, they offer this possibility where you're part-time emergency medicine and you're part-time hospitalist, but it all works together where you have a full-time job kind of thing. And
Yeah.
so they set it up so that you can do emergency and critical emergency and internal medicine all together if you wanted to do that, or you could just do locums and just work emergency medicine job somewhere and then a hospitalist job, and you can change it up however you want to. So it's completely doable, depending on if you want to do academics or if you want to do just community. They're both available to you, however you want to do it. So it gives you a nice flexibility to be able to do both if you wanted to. Completely doable.
Understood, understood. So it gives, yeah, the flexibility of that extra 2 years gives you essentially way more options than I would have as a
Right.
EM trained, for sure.
Because emergency medicine work and internal medicine work are two very different things. And
Hmm.
so in the emergency department, things are higher paced, it's much more high stress, it's high demand.
Yeah.
And sometimes you just want to kind of take a break from that, and you just want to get away from that and just decompress a little bit. And so that's where being a hospitalist, where things are a little bit slower, you have time to sit and talk with your patients and you have time to think through their problems. It makes things a little bit easier. It kind of changes things up. It adds a little more variety instead of the whole high stress, high workload emergency department kind of thing that you see.
Okay. Okay. Thanks for that. So there's multiple avenues to getting to critical care, and you don't have to do specifically EM, IM, correct?
That's correct. So if you're truly interested in critical care, there's a lot of ways that you can get to that destination. If critical care is the specialty that you're looking at, you can do it through emergency medicine, just straight emergency medicine, and then you can do critical care on top of that. That's an additional 2 years of work. You can do it through internal medicine, which is another 2 years in addition to your internal medicine program. You can do it through EMIM.
Hmm.
That's going to be 1 extra year if you decide to do it that way. You can do it through anesthesiology. You can do it through surgery. And so there's multiple ways of getting to critical care, if that's truly what you want. Now, if you wanted to do pulm critical care, then I would recommend just doing internal medicine and just going through that avenue if that's what you wanted. But if you're just doing just critical care, many ways of getting to that
Hmm.
fellowship or that board.
Yeah. So when you were a medical student, did you always knew that you wanted to do critical care in the end, or were there other medical specialties or residencies you were also interested in as well?
Yeah, so I started medical school thinking that I just wanted to do straight emergency medicine, and that was all I wanted.
Hmm.
But when I did my medical school rotations, I discovered that I kind of liked those other things. I liked working in the ICU as well. I liked seeing these critically sick patients who are just really sick and just seeing them get better. There was a sense of satisfaction to me for seeing that and doing that. And so that sort of piqued my interest in that. Emergency medicine is great. It's an amazing fellowship. It's an amazing job. I highly recommend it. But
Hmm.
one of the downsides to emergency medicine is that you see the patient, you figure out what the problem is, and then you send them on. And so you never really get to see like a lot of the great outcomes that sometimes you can with critical care. So I wanted to have both aspects of that. And so
Hmm.
that's why I kind of ended up doing both. So
Okay. Would you have done anything differently along this path?
no, I would, if I had to go back and do it all over again, I would totally do this again.
Hmm.
I would do emergency medicine and internal medicine, even though now like I'm primarily in critical care medicine. Like I feel like I have a, a good blend from both specialties that has prepared me to be a critical care physician. And so I have the procedural aspects of emergency medicine, and I have the medical background from internal medicine, and they both kind of blend together and work really well in the critical care environment. So I have no regrets whatsoever of doing this.
Okay, thanks for that. So what do you think are like the personal qualities or traits of a student to make a successful critical care physician?
So you have to be able to think on your feet.
Hmm.
You in the emergency department, I mean, you are well aware of this.
Hmm.
It's there's constant interruptions. There's constant things that are going on that are
Hmm.
sometimes out of your control. So you always have to be able to manage your time well. You have to be able to prioritize, okay, I'm going to see this patient, I'm going to see this problem, I need to address this first. So you have to prioritize, like, what's the most important use of your time at that time? What's the most critical things that you have to get done?
Mhm.
So um, prioritizing your time is absolutely essential. And both in emergency medicine and in critical care medicine, you're working with very high intense, high risk, critically ill patients a lot of times. And so a lot of times you're going to be in situations where you just don't feel comfortable. You don't feel like, you've got a good handle on what's going on. And so another aspect of the job is, I would say, you have to eventually feel comfortable with being uncomfortable with the situations that you're dealing with. And I don't know if that kind of makes sense the way I'm saying it, but you have to be okay with the amount of stress and the amount of critical decision making that you have to deal with. And so,
Mhm.
but it's all totally worth it. It's not anything that I would change or alter about the field. It's just the reality of how emergency medicine is and how critical care medicine is. You just have to deal with that environment.
Yeah, yeah, I definitely agree with that. You have to be able to be okay with the unknowns. That's you may not be able to figure out, but we'll have to continue diagnosis and testings and treatments and hope for the
Correct.
best.
Yeah.
And yeah, so I appreciate that. So, what do you like the most regarding being a critical care physician?
For me, I personally like seeing people get better.
Hmm.
So I like it when a patient comes into the ICU on day one and they're on life support, they're on the ventilator, they're just, sick as stink, and they're going to die unless you absolutely intervene and help them out. And then 4 or 5 days later, when you're still in the ICU, you get to see that patient, you get to take them off life support, and you get to see them recover, and they're working with physical therapy and they're making a comeback. That for me is the greatest benefit that I see from working in critical care. I genuinely enjoy seeing patients get better.
Hmm.
And so it's just knowing that these patients absolutely need you as a physician,
Yeah.
and just seeing the benefit and the good that you're doing for them as a doctor, as a critical care doctor, is the biggest benefit that I get from it.
Okay. And on the other end of the spectrum, what aspects do you dislike about critical care?
Um, I would say that it's not just critical care, it's just medicine in general. Medicine is very tasky. There's lots of little minutia things that you wouldn't think about that you have to deal with, like on a day-to-day basis. Does the patient have a diet? Does the patient have,
Yeah.
DVT prophylaxis? Does the patient have this? And did you
Hmm.
order this test? And did you like? It's just very tasky. It's very there's hundreds of little decisions that have to go into um, making it work on the
Hmm.
floor. You don't necessarily have this problem in the emergency department where you're just ordering your routine tests and then you find your problem and then you send them somewhere else or you fix the issue.
Hmm.
Emergency medicine, I find, is not as tasky, but
Hmm.
critical care is definitely very tasky. And you're constantly being interrupted by nurses because a patient may not be doing well in this room.
Hmm.
And so it's the interruptions and the taskiness of critical care in general that probably would be the thing I don't like the most.
Okay. All right. And I always ask, are there any myths that you think are unfair to critical care or you think are that are untrue?
Myths.
Yeah,
What
I'm
do you
not
mean?
not sure, like orthopedics don't like to do medicine, things like that. Is there even
No,
any we
not
can
that I know of. Like,
yeah.
there's this myth that critical care doctors are apparently really smart, and
Uh-huh.
so completely not true. That is not true at all. But a lot of times, other like hospitalists, especially, they feel the
Mhm.
need to come to me to ask about a question. To ask a question about a patient who may not be doing very well, and
Yeah.
they just want my opinion. And I'm like, I'm not any smarter than you are. I have the same background that you do. So, what do you think? And so the myth is that somehow critical care ICU doctors are smart, and that's not true. We're just like everybody else, I promise. So,
All right, fair enough. You're able to do a fellowship during as a or added on a fellowship, even though you're a full-time attending. How has
Mhm.
critical care shaped your work-life balance then?
I have a job where fortunately, so in critical care, I work an average of 140 hours a month. So if you do critical care, you're going to be working somewhere between 140 to 170 hours a month, just
Hmm.
depending on what your shifts are like.
Hmm.
Fortunately, I have a job that allows me to take all those hours and pack them all together. And so I work all my 140 hours in a 10-day stretch. And so I work for 10 days, and it really sucks to work all those hours for 10 days. But then the benefit is that I have close to 20 days off. And so
Hmm.
that has allowed me to pick up some extra time doing neurocritical care and learning more about that and working towards getting that board to kind of help me to become a better critical care physician overall. So having a full-time job and a part-time fellowship is very labor intensive and hour
Yeah.
intensive. So I'm still working on that work-life balance, but
Hmm.
this isn't forever. It's just going to be for another year or so. So
Yeah. Yeah. Let's hope so until you pursue
yeah,
another
let's hope
fellowship.
so.
So,
I will graduate one day, I promise.
well, you already graduated. You
I
just,
know, but you know what I mean.
yeah, yeah. So how has critical care had how has it changed over the years? And then can you discuss it in light of COVID-19 as well? And if you want to also discuss what you think the future of critical care would be.
So COVID-19, I mean, even so emergency medicine, internal medicine, and critical care medicine, COVID-19 has completely hit all of them. And
Hmm.
so you're directly in the front lines of COVID-19 if you work in any of those specialties. So you've seen plenty of COVID, I'm sure, in the emergency
Hmm.
department. As an ICU doctor, I see plenty of COVID in the ICU, and the hospitalists are managing all the non-ICU COVID patients. So those are the top three specialties: EM, IM, and critical care that have been directly impacted by COVID. So
Hmm.
we get lots of COVID exposure, lots of COVID. Exposure is not the right word, but we see a lot of COVID patients.
Hmm.
Um, in terms of how things have changed, or how I think it's going to change in the future, I think you're going to start seeing more and more of a trend towards managing patients in an outpatient setting. For example, like heart failure patients, we're
Hmm.
getting much better at managing their symptoms and managing their problems before they get to the point that they have to come to the hospital. And so, with that said, when people who are going to be admitted to the hospital, they're typically going to be sicker, I think, in the future than they are today
Hmm.
as we get better with outpatient management and outpatient follow up and things like that. And so I think in the future, hospitalists are going to have to be more comfortable managing sicker patients. And so I think you're going to see a trend where hospitalists are going to be managing patients more where they're critically ill, where it would qualify as an ICU patient. There's a shortage of critical care doctors in the future.
Hmm.
Society of Critical Care Medicine predicts that there's going to be a shortage in the next 20 years of ICU critical care doctors. So
Wow.
hospitalists are going to have to eventually step up and start taking care of these patients. And I think you're going to see technology change in the future
Hmm.
for critical care doctors, especially in terms of like hemodynamic management and stuff
Hmm.
like that. So you might get a patient who's really, really sick, who's on multiple pressors, and a lot of times it's hard to pin down, is this person sick because it's a cardiac issue? Is it because of sepsis, or is this like a multifactorial kind of thing?
Hmm.
And so I think in the future, you're going to see hemodynamic monitoring and stuff like that sort of get better, where it's going to be not as invasive, whereas nowadays we have to do swans and stuff like that. In the
Hmm.
future, I think you're going to see better hemodynamics that doesn't require such invasive equipment. And so not only that, but in other areas such as in neurocritical care, whether a person is like vasospasming, you're going to see
Hmm.
other technologies that are going to come forth to kind of make our jobs a little bit easier. So,
Yeah. You talked about technology. What about the aspect of tele medicine as well?
So I've never done telemedicine, but I know people who have, and so I
Hmm.
can't personally speak about telemedicine, but
Yeah.
it's become something that's been invaluable for smaller hospitals who can't hire a dedicated critical care intensivist to work in their ICU, where they might have nurse practitioners or they might have hospitalists who sort of do the groundwork or the legwork, and then they have a critical care physician who's on the other end of the phone so that they have a camera just like this and they can see the patient and they understand the vitals and they can talk to the intensivist, and the intensivist sort of gives them advice on how to manage the patient. And
Hmm.
so it allows, it's one potential way of fixing the shortage in critical care physicians that we're going to see in the future. So you might see more of that as well. I hadn't thought about that, but that's a good point. But I've never personally done it myself. I'm actually interested in it. I might want to do it one day. So
Yeah. And you touched upon NPs and PAs, or what we call mid-levels. Do you work with them, and then do you see their roles changing in the future?
yeah, so I work very closely with nurse practitioners in the ICU,
Hmm.
and I think that they are absolutely invaluable
Hmm.
in helping me manage the patients that I do. So if I'm the only ICU attending and I have 24, 30 patients that I'm managing, I can't do it all by myself.
Hmm.
And so having one or two nurse practitioners there to kind of help with procedures, to help with seeing the patients, to help with um, nursing pages and things like that becomes very, very helpful. So in the ICU, nurse practitioners are absolutely invaluable.
You talked about a severe shortage of critical care physicians. Does that mean that you think in 10, 15 years, the job market will still be great?
And there's a tremendous demand and a growing demand as our patient population becomes sicker for critical care physicians. So I think if you specialize in any of those specialties, you're going to do fine.
Okay. All right. Are there any additional resources that students can learn more about critical care? Any websites or
Yeah, so if you're interested in emergency medicine, of course, there's IMRA, there's American Board of Emergency Medicine, there's those websites. If you're interested in critical care, there's Society for Critical Care Medicine. They have a lot of resources that you can look up, such as they have their own textbook if you wanted to download that and just read that. There's tons of podcasts. There's tons
mhm,
of like YouTube videos,
mhm,
people who make sort of foam free access to critical care stuff. Scott
mhm.
Weingard and all that kind of stuff. He does a lot of critical care podcasts and things. And so there's plenty of resources and plenty of things that you can look up if you're truly interested in that, and if it's something that you really want to consider as a job opportunity in the future.
Okay. Thanks for that. And lastly, my last question is, what's your number one tip for students who wants to go into critical care?
Um, Looking back now, knowing that I was going to do critical care or emergency medicine, um, I would say that when you're doing your rotations in
Mhm,
medical school, such as when you're doing your neurology rotations or you're doing an OB-GYN rotation, that I would learn as much as I can from those rotations while you're in that rotation. And I get it, you're not going to be an OB-GYN doctor, you're not going to be a neurologist, but
mhm,
you are going to see OB-GYN patients and you are going to see stroke patients when you're an emergency doctor or when you're an ICU doctor. And so
mhm,
now would be the time when you're rotating through those specialties to become familiar with the major points that you're going to see, because emergency medicine and critical care medicine are so broad in what you're going to see in terms of the problems that the patients are going to have. And it's good to have a really solid foundation on just about everything you could possibly encounter. So when you're doing cardiology, get really good at heart failure and get really good at managing
mhm.
heart attack patients and stuff. So that would be my advice. I would, if you're going to do a very broad specialty such as that, then I would take advantage of any rotations that you have and learn the most you can, because they're going to be invaluable to you when you actually start practicing in the real world.
Yeah. Yeah, that's a great tip. Now, do you have anything else that you'd like to add that the viewers should know about critical care that I missed? If not,
No,
then
not
it's
that
fine.
I know of. I think I'm okay.
Okay. All right. All right. Thanks, Brad. And definitely thank you for taking the time to do this interview because you've just done a crazy schedule and being able to do this interview with me was freaking amazing.
Anything for UConn. I got you.
All
No problem.
right. All right. Thanks. Thanks again.